141. A 37-year-old woman was admitted to the emergency department with high fever, nausea, and vomiting. He revealed increased abdominal pain in the paramedical region, rebound tenderness over McBurney's point, and a positive psoas test. Blood test show marked leukocytosis. What is the most likely diagnosis? So this is a classic presentation of a patient with appendicitis. So other terms you need to know about your appendicitis is the McBurney's point, which is 1/3 of the distance between the anterior superior umbilical spine and the umbilicus. So this is where usually the point of maximal tenderness in a patient with appendicitis, and it's also the site where you usually do an incision. Other eponymous signs for appendicitis are Robsing sign, ellipsoas sign, and obturator sign. Robsing sign is RLQ pain with palpation of the LLQ. Remember, the pain's in the RLQ. Robsing starts with R, so you don't get confused that the pain is in your RLQ. Ellipsoas sign and obturator sign are two signs which are easily confused with the other. Ellipsoas sign is pain on passive extension. Pain and passive extension at the right thigh. Your obturator sign is pain on passive internal rotation. Obturator somehow sounds like rotate, so actually just remember obturator rotation. Your ellipsoa is extension. So 141, again it's letter D. 142, what is the organ most susceptible to blunt trauma and is frequently involved in upper torso penetrating wounds? So it's actually your liver due to its large size, which makes it susceptible to blunt trauma. So 142, the correct answer is letter C. 143, abdominal compartment syndrome is defined as intra-abdominal hypertension sufficient to produce physiologic deterioration and frequently manifests via end organ sequelae such as. So your abdominal compartment syndrome usually presents with increased pulmonary inspiratory pressure. Now, as you can see here, an increase in abdominal pressure is going to cause compression of the kidneys, leading to decreased urine output. A decrease in venous return, because of the compression of the inferior vena cava, is going to cause all of these effects, ultimately leading to decreased cardiac output, leading to ischemic ischemia and splanchnic ischemia. Also, increased abdominal pressure is going to increase the pressure in the thoracic cavity because it's going to push the diaphragm upward. So you're going to have increased pressures, decreased compliance, and increased CVP readings. So these four are actually the more important ones. Increased pulmonary inspiratory pressure, increased cardiac afterload, decreased urine output, and decreased cardiac preload. So 143, the correct answer is, again, your letter B. 144, the most unforgiving organ in the human body is your pancreas. Your pancreas is surrounded by numerous important structures in your blood vessels, and minor trauma to the pancreas can lead to the release of pancreatic enzymes leading to pancreatitis. That's why it's called the unforgiving organs. As they say in general surgery, there are only 3 rules. Sleep while you can, eat while you can, and never, ever, ever touch the pancreas. So for 144, the correct answer is letter D, pancreas. I've actually just include this question because there are questions in the surgery board exam which are very, very basic and quite trivial. But again, surgery is one of the easier subjects in our board exam as compared to other clinical subjects. And the questions were usually based off the first few paragraphs in each chapter. So a little review won't help because surgery, one of the subjects, is going to pull your overall score higher. 145, in the management of a solitary thyroid nodule based on the Bethesda criteria, what is the next step if FNAB reveals a TEPI of undetermined significance? So the Bethesda classification will guide you ultimately in your future management. So I'll just zoom this. When you have a solitary thyroid nodule, the initial test you're going to do is you're going to do an FNAB. If it's non-diagnostic, you're going to repeat your FNAB with ultrasound guidance. If it's benign and you aspirate cyst-like fluid, you should do an aspiration. If it reaccumulates, you need to do it another time. Then you need to repeat it another time again if it recurs. And if it's more than 3 times, you should do a thyroidectomy. If you find a colloid nodule, you should just observe. However, if there's continued growth and compression of the surrounding structures, you have a patient developing dyspnea and dysphagia, you can already do a thyroidectomy. In patients with a TEPI of undetermined significance, you should repeat the FNAB. If you see follicular neoplasia or suspicious for follicular neoplasia, you should do a lobectomy. If it's suspicious for malignancy, you should do a lobectomy or a near total thyroidectomy. And if it's malignant, you should do a near total or total thyroidectomy. So 145, the correct answer is letter D, repeat FNAB. 146, what lens is used to correct hypermetropia? Is it concave, convex, cylindrical, circular, or cone? So your hypermetropia or hyperopia is farsightedness. You correct your hyperopia using your convex lenses. For myopia, you're going to have short-sightedness. What you correct it with are your concave lenses. For astigmatism, you're going to use your cylindrical lenses, as summarized in this table right here. So 146, hypermetropia or hyperopia, you use a convex lens. 147, based on wound classification, penetrating abdominal injuries are examples of. So penetrating abdominal injuries are examples of contaminated wounds. So along with it, you have your large tissue injury, enterotomy during bowel obstruction. You have clean for hernia repair, clean contaminated for controlled entry and in an GI tract, such as your cholecystectomy or elective GI surgery. If you do colorectal surgery, that's the different type of class 2. For class 3, as I have mentioned, again, penetrating abdominal trauma. For class 4, you have perforated diverticulitis, necrotizing soft tissue infections, and these are all considered dirty. So 147, it's letter D. 148, a type 1 choledochal cyst described as fusiform or cystic dilations of the extrahepatic biliary tree is the most common type of choledochal cyst. The ideal management for this condition is Type 1 choledochal cysts are the most common. More than 50% of your choledochal cysts are type 1. For types 1, 2, and 4, you need to excise the extrahepatic biliary tree and include a cholecystectomy with a Roux-en-Y hepaticojejunostomy. So by the table, I took this from your K0 handouts. For type 1, which is fusiform dilation, you're going to have to do an excision and a Roux-en-Y. For a saccular, you can do an excision, and you may also do a Roux-en-Y. For choledococele, which is found near the ampulla, you need to do a sphincterotomy. 4A and 4B are extra and intrahepatic and extrahepatic respectively. For extra and intrahepatic, when it involves already the liver, you should do a segmental liver resection. If it's extrahepatic, you can still do an excision and a Roux-en-Y. For intrahepatic, you should do liver transplantation. Class 5 or type 5, you need to do liver transplantation already. So in 48, the correct answer is letter D, cholecystectomy with a Roux-en-Y hepaticojejunostomy. 49. Which of the following statements more accurately describes total or central parenteral nutrition rather than peripheral? So the difference is in their axis. Central means you have to find the central vein. Peripheral, you need to find the peripheral vein. For central or total parenteral nutrition, due to the large diameter vein, you can give a higher dextrosity infusion. For peripheral, you can only give 5 to 10%. Your TPN can give the entire nutrition requirements of the individual, while your peripheral parenteral nutrition cannot. It's only appropriate for short periods and is not appropriate for patients with severe malnutrition. 49, the correct answer is letter A. Letter B is incorrect because your TPN is used for patients with severe malnutrition. It may be used for longer periods as compared to your peripheral parenteral nutrition. It's administered by the central veins, as its name suggests. 150, hernia associated with Meckel's diverticulum. So the hernia associated with your Meckel's diverticulum is your Litter's hernia. How I remember this is whenever I think of Meckel's diverticula, I always see a child with abdominal pain. So the child is little, so Litter's hernia. So 150, again, it's your Litter's hernia. Litter's hernia. So your Amiant hernia is your hernia associated with your appendix. Your Greenfeld is the superior lumbar triangle. Your pantaloon is where you have your both your indirect hernia. Internal hernia is hernia inside the abdominal cavity. So it's your Litter hernia. 151, tumor marker most useful in following the course of treatment in women diagnosed with advanced breast cancer. So your CA15-3 levels are most useful in following the course of treatment in women diagnosed with breast cancer. So you have summarized this table showing the associated cancers. Again, your tumor markers are not used to confirm a diagnosis, but instead it is used for screening and possibly for the for checking if there's recurrences for monitoring treatment. A good way to remember your CA tumor markers is by drawing them out. So 19, -9, 15-3, and 125. So 19-9, your number 9, you just do a mirror image of it. It now looks like a letter P, so it's pancreas. Your 15-3, you drop it down. You add 2 points there. It already looks like a breast. Your 125, I just remember it as a variant. I don't have any mnemonic for it, sorry. 151, the correct answer is letter D. 152, what is the overall most common indication for splenectomy? The most common indication for splenectomy is trauma to the spleen, whether external or iatrogenic. So 452 is letter C. Others are just indications also for splenectomy. However, the most common is your trauma. 153, which among the abdominal wall defects in the newborn period has the worst prognosis? So your gastroschisis and your omphalocele are two abdominal wall defects. Your omphalocele has a sac, while your gastroschisis has no sac. Counterintuitively, it's actually your omphalocele which has a worse prognosis because they usually have associated congenital defects, not only your omphalocele. Your gastroschisis basically just has a defect with no sac. Urgent repair may afford the patient greater mortality and morbidity benefit. Omphalocele, on the other hand, usually has associated defects such as the pentalogy of Kendrell, cardiac defects, renal defects, and vertebral defects, among others. So 153, the correct answer is omphalocele. 154, the criminal nerve of Grassi is derived from. There were lots of anatomy questions in our surgery exam. So it's actually the posterior vagus nerve which sends off the criminal nerve of Grassi. Now the criminal nerve of Grassi supplies the posterior fundus, and this is the one that's usually missed during highly selective vagotomy. So that's why it's a criminal nerve. 154, the correct answer is your posterior vagus. 155, criteria for SIRS except temperature more than 38, heart rate more than 90, tachypnea more than 20, WBC less than 12, immature neutrophils more than 10. So among these, you can easily spot out, even if you haven't memorized the value, a WBC count of less than 12,000 is actually normal, so it's not a criteria for SIRS. So this one is taken from Schwartz. Remember, infection only means that there's an identifiable source of an insult. If there's an infection, the patient is presenting with SIRS, as we have previously mentioned, we call that already your sepsis. If there's sepsis and there's organ dysfunction, we call that severe sepsis. And if there's sepsis and cardiovascular collapse requiring pressors, you have your septic shock. But this one is a very old way of differentiating sepsis from severe sepsis from SIRS. Now we have the SOFRA criteria. 155, correct answer is letter D. 156, during the secondary survey, the patient and surrogates should be queried to obtain an ample history AMPOL is actually demonic for the secondary survey. The AMPOL consists of the following, except your AMPOL stands for allergies, medications, past illnesses, last meal, and events. So for 156, the incorrect one is airway and cervical spine stabilization, because this is actually part of your primary survey, which includes your airway and cervical spine stabilization, breathing, circulation, disability, and exposure. 157, possible complications of spinal headache include hypotension, high spinal block, and post-dural puncture headache. Spinal headache may be decreased by, so this one is taken from Schwartz. Spinal headache is related to the diameter and configuration of spinal needle. You can reduce spinal headache by reducing size of the needle to 25 or 27 gauge. Others are also possible treatment modalities for spinal headache. However, the one that's been proven is by using a smaller needle. 158 was the most common of the primary esophageal motility disorders. The one that's most usually cited in exams is achalasia. However, the most common by incidence is your nutcracker or super squeezer esophagus. It is characterized by a mean peristaltic amplitude of more than 180, but there is a more normal peristaltic sequence. So that's your nutcracker esophagus. Your DS is your corkscrew esophagus. Your achalasia would have a bird's beak appearance. This is due to increased pressure, failure of relaxation, and peristalsis. 159 was the most common organism associated with pyogenic liver abscess. For pyogenic liver abscess, the most common are your coliform bacteria found in your colon. Again, it's your Escherichia coli, followed by S. faecalis, Klebsiella, and Proteus vulgaris. Your pyogenic liver abscesses are usually found right of the liver, and they are actually the most common liver abscesses. So for 159, it's your Escherichia. 160, true statements for amoebic liver abscesses, except. So, again, there are questions, same as the previous subjects, are taken verbatim. For your surgery, it's taken from Schwartz. Amoebic liver abscesses are most commonly located in the anterior superior aspect of the right of the liver. Usually, you can see a mildly elevated alkaline phosphatase level. The presence of diarrhea, even though this is an amoebic infection, is unusual. Metronidazole for 7 to 10 days is the treatment of choice. And abscesses of the left lobe of the liver should be aspirated or should be treated due to the risk of rupture into the pericardium. So for 160, the incorrect answer for this is your treatment with metronidazole. It should not only be for 3 to 10 days, but instead for 7 to 10 days or even longer. So 160 T. I don't have topics to discuss for your surgery, but I would really suggest that you read your ABSITE. Previous board exams have utilized the ABSITE review of Schwartz as its source of questions. However, even if the questions do not come from the ABSITE, it's still a very good review book. Next up, we have internal medicine.